So let's look at this. We have huge numbers. We need 250,000 hearts every year in the United States, and we have only 4,000 donors at the max. The plateau happened a few years back, as Dr. Gokhale showed. There were only 2,500 usable donors in the United States every day as far as heart transplant donors were concerned. The recent push or the rise has primarily happened because of what he mentioned later. We've started using borderline hearts. We've started using DCD donors in many countries. We've started utilizing organs not from standard criteria donors, that is older donors, 50, 55 years old donors. We've also taken up donors who have had mild coronary artery disease. We've performed coronary artery bypasses up to, the standard recommendation is up to 2 coronary artery bypasses. But in spite of doing all of this, there is, and yes, the morphine epidemic. Because of the opioid epidemic in the United States, you have nearly 1,000 donors who have been added to the standard donor pool. So when even you're looking at 4,000 donors a year, they will never be able to fit that gap of 50,000 that are required. So what happens to all of the others? Unfortunately, they die. So a solution is not a solution unless it is a real-world solution. Now, when you have patients with terminal heart failure, you have only 2 options. Patients who have already undergone CRT, resynchronization, drug therapy, intravenous administration of inotropes, sticking around the hospital with balloon pumps and various forms of support devices, they need a human heart. Unfortunately, it's not available. Right? So what do? You have to look at a synthetic or an artificial implement, and there's nothing else that you can use except a left ventricular assist device. Now, going forward, this is exactly what I mentioned, and I will skip that slide. Look at what are the alternatives. If you're looking at the alternatives, heart transplantation started in the late 60s. It's been 50 or 51 years of heart transplantation now. Ventricular assist devices started almost the same time. The amount of energy and time that not just the American Federal Authority, the funding agencies, that's the National Institute of Heart, Lung and Blood, and also a surgeon called Michael DeBakey, working with the American Academy of Sciences, pushed a lot of funding towards the development of support devices, not just replacements for the heart, but just ventricular assist devices, because there were many patients who underwent heart surgery who would not be weaned off bypass. So they required assist devices, and that's where it started. Now, in the 50 years, they first thought that they'll imitate the heart by creating a pulsatile ventricular assist device. Only over a period of time, they realized pulsatile devices were large, they used to break down very frequently, and they used to have thrombosis, which would probably cause severe stroke. In 50 years, they moved from a pulsatile device, realizing much later that a continuous flow pump, which is the current technology, would be adequate for sustaining human life. So we moved on through 3 generations of pumps. And I'll show you that slide in the end. And what has happened? In 2000, ISHLT mentioned that of the 19% of transplant recipients in the year 2000, 19% were mechanically supported, having VADs. In the year 2012, it has gone up to 40%. So there's a great deal of worldwide acceptance. And if you look at the class of patients, when you break down the Intermax grade, you'll see from Intermax 1 to 7, the 1, 2, 3 are the sickest. And if you can look at it, data and research has now told us, and outcomes have told us, utilizing a VAD in those patients who are very, very sick is probably not the best way forward. But the ones who are less sick are the ones who probably cannot wait for a heart transplant going forward. Best to utilize a VAD. So you look at the acceptance, 36.4% and nearly 30% in most of those patients who are class 3B and 4, and so on and so forth. So though the ones who are fitter are the ones who are not accepted yet for a VAD simply because of the concerns with VAD complications, we must understand that VAD technology is progressing rapidly in many ways that I'm going to show you much later. So if you look at the head-to-head survival, which Dr. Gokhale just did mention, look at on the left-hand side, transplantation in the first 1 and 2 years. You can look at the gap between the first decade, 1980s to 90s. You look at the survival in the first 2 years and look at the survival in the current era. There's probably a 5 or 7% improvement. Why have we not improved in 50 years? Whereas in VADs, you can look at a previous generation VAD, which is called the HeartMate 2, which was in the early 2000s. It's the first decade of this century. That used to have a 2-year survival of 60%. In 10 years, the survival rate of a mechanical heart has improved by 14%. This is how technology is disrupting your natural replacement, which you call a human heart. So it is not good to ignore it. I think we should embrace it. There's a reason why we should do that. Look at this. I hope this slide is a little more clearer. these are the center-specific exclusion criteria for heart transplant. Body size really doesn't matter as long as the donor probably has a reasonable BSA. But older than 70, no heart transplant. High pulmonary artery pressure, no heart transplant. RV doesn't matter. Urgent situation, you don't get a heart. Comorbidities, still manageable. Patients who have had malignancies within 5 years, not acceptable. Patients who have end-stage renal disease, not acceptable for a heart. Patients who have lung disease, more than mild to moderate, are not acceptable for a transplant. Those who are obese, BMI is more than 30 kilograms per meter square, not acceptable. But look at LVADs. Except in younger children or smaller children, which it mentions 1.2, but now we have VADs that can be put in even neonates, allowing them a chance to grow up, get a heart later. You can do it when patients have very severe PAH. Paul Wood units of greater than 8, you can still put a VAD when a patient has heart failure. You can use it when patients have cancer. You can use it when patients are even on dialysis. You can still do a heart transplant. You can put a VAD there. You can, your only contraindication for a VAD, simply because you have more frailty, is you have worse outcomes, is when you have a BMI less than 15 or a BMI more than 45. So the VAD has a much bigger range where heart transplantation has a very narrow window of opportunity for patients with terminal heart failure. So that's why I think VADs are better. If you look at the adverse event profile of the latest VAD versus what you see with heart transplantation, you look at a 30-day and a 180-day survival. Other than the standard complications that you have with heart surgery, you could see that pump thrombosis, pump replacements, hemorrhage and stroke are almost zero with the latest pump, with 30 days and 180 days, almost zero. There's no incidence of pump exchange now anymore. But look at heart transplantation. 35% of patients, the green arrow, 35% of patients have graft failure within the first 30 days. When you are talking about deaths, I'm not talking about in general. If you have a 10% mortality, 3.5 of them have graft dysfunction. Another 20% roughly have multi-organ failure. 15% of them have infection. So you have a significant comorbidity that comes along with the heart transplantation because it's an organ coming from elsewhere. If you're looking at complications during a heart transplantation, you have a serious problem called primary graft dysfunction. Unfortunately, as you look for borderline organs, you look for not standard criteria donors, the incidence of primary graft dysfunction goes up significantly. You also have an issue with intraoperative bleed and coagulation disorders many times, and hematological disorders, not just in the short, but even in the long term. A donor heart sometimes has issues with cardiac rhythm and rate, which requires additional support. Immunological complications, I'll come to them later. So a heart transplant is not something that we can say is a panacea for all the problems that we have. Not going into primary graft dysfunction. Primary graft dysfunction, once detected and if not treated well, has a 30 to 40% mortality at the end of it. And to imagine that 10 to 15% of all patients who undergo heart transplantation have some grade of primary graft dysfunction. Acute cellular rejection happens within the first 3 to 6 months. Hyperacute doesn't happen anymore, but acute cellular rejection is basically a T-cell response. So blocking it well is an important factor. It requires tacrolimus, it requires steroids, it requires monoclonal antibodies. Many a times it even requires ATG. And if not controlled well, it could probably lead to chronic rejection. If you're looking at antibody-mediated rejection, that is a B-cell mediated response. It happens more in the long term. Unfortunately, it also leads to one of the most grave complications in the long term with transplants, that is coronary allograft vasculopathy. You require a retransplant in many of those cases. So survivals are seriously affected. This is other than the long-term complications of heart transplantation, primarily caused not because of the procedure, but also because the side effects of the drugs that we use for transplantation, like hypertension, renal dysfunction, hyperlipidemia, bone complications, malignancies, so on and so forth. So if we go to the VAD, other than the standard complications that you have with VADs, you could probably have infection, thromboembolism, GI bleeding, stroke, and right ventricular dysfunction. I don't go too much into this, but give me 2 more minutes and I'll sum up. This is the latest, which appeared in the NEJM in May 2019. This is a comprehensive study and reporting of the first 1,024 patients who underwent the HeartMate 3 device. And it shows you some remarkable results. Of the 1,024 patients who were randomized to either axial flow pump, which was the previous generation, and the HeartMate 3, you can see that the primary endpoint was served, which was basically 2 years freedom from replacement of device, and generally replacement of devices for pump thrombosis, which was significant with the HeartMate 2, but almost eliminated with the HeartMate 3. You're looking at disabling stroke, more than a Rankin score of 3. You're looking at a significant improvement there too. If you go forward, you look at the primary secondary endpoint, that is pump replacement at 2 years. 96.9% patients had freedom from pump change. Amazing advance. If you're looking at strokes, you can see that the green bar on the extreme right-hand corner, you could see the incidence of non-fatal strokes with HeartMate 2 were reasonably high. Almost 1/3 of them now with the HeartMate 3. You look at deaths or severe stroke, that is probably even reduced by 1/3. You look at a freedom from all strokes, in 10 years it is brought down by 14% using a VAD. So I think if you look at this data more accurately rather than generalize, you would realize that VADs have made significant inroads into replacing the human heart in the future. The survival of the HeartMate 3 at 2 years and the survival of a heart transplant now is the same. And I have no reason to believe that if it has happened in the last 15 years, it is going to 100% overtake the heart transplant in times to come. A quick review of the hazard function for all kinds of stroke and bleed. You can see the HeartMate 3 is better. So for you to take-home message is the HeartMate 3 is a more advanced pump than the HeartMate 2, simply because it works on a design called the centrifugal pump. And the centrifugal design avoids many complications that are associated with VADs. So the net clinical benefit of using a HeartMate 3 over a HeartMate 2 would 22 events in 100 patients were avoided in a year, 20 strokes were avoided, and 68 less bleeding events happened as far as GI bleed is concerned. To sum it up, the HeartMate 3 is a more forgiving pump. It has a significant reduction in pump thrombosis. It has a reduction in strokes, reduced incidence of GI bleeds, reduction in cardiac arrhythmias, and also in readmissions and time spent in the hospital. The last slide will tell you this. The pump is getting smaller, the pump is getting lighter, the technology is getting better, and now you're going to have something we call a coplanar, which has already been done. The pump is fully implantable. You have no driveline externally, so you have no fractures, you have no infection. Now here's the direct head-to-head between a heart transplant and an MCS. The transplant has a wait list. It cannot be an elective procedure. It transmits infection. It needs immunosuppression. It needs biopsies. It has an elevated malignancy risk. It needs repeat biopsies. It has a rejection risk. It cannot be minimally invasively implanted. It is not readily replaceable. It is not amenable to technology. It doesn't have a partial support option. It doesn't have a recovery option. Once transplanted, you've got to only retransplant once again. And lifelong anticoagulation driveline, yes, a big advantage with the heart transplant, but everywhere else, the MCS scores. Everywhere else, an artificial heart scores over. So my last slide, the future is an off-the-shelf, readily deployable, greater bio-hemocompatible, miniaturized implement that can be wirelessly powered, implanted through a minimal invasive incision. We know all around the world a resource-constrained solution like the human heart will never be an alternative to a diseased and damaged human heart. Titanium is the answer to the real-world problem, and the only other viable alternative in the foreseeable future is a xenotransplant. Thank you so much.